Hello, good afternoon, everyone. It's my pleasure to welcome you to this virtual congressional briefing, Understanding the Immune Response to COVID-19. I'm Cynthia Benz, and I serve as the Senior Vice President of Public Policy at the Personalized Medicine Coalition. The Personalized Medicine Coalition is a multi-stakeholder education, advocacy, and evidence development organization with more than 200 members from across the healthcare spectrum. Our collective goal over the past 16 years has been to advance the development and integration of personalized medicine into the healthcare system for the benefit of patients. We're co-hosting today's educational briefing with Adaptive Biotechnologies in cooperation with the Congressional Personalized Medicine Caucus. The Congressional Personalized Medicine Caucus convenes a bipartisan group of lawmakers to educate themselves and their colleagues about the increasing health and economic benefits of personalized medicine. The caucus's activities help to inform legislation that encourages increased research, innovation, and access to personalized medicine. As you see on this slide, the caucus is co-chaired by Senator Tim Scott, Senator Kyrsten Sinema, Representative Eric Swalwell, and Representative Tom Emmer. We'll start with some remarks from the caucus leadership to kick off today's briefing.
Hi, I'm Senator Kyrsten Sinema. Welcome to this virtual briefing examining the most current research on COVID-19 immune responses and the long-term impacts on COVID survivors. I'd like to thank the Personalized Medicine Coalition and recognize my fellow caucus chairs, Senator Tim Scott, Congressman Tom Emmer, and Congressman Eric Swalwell. When we began this caucus, we had no idea that a global pandemic would upend Americans' lives. While we saw medical researchers and innovators step up to develop new diagnostic tests, therapeutics, and vaccines, there's still so much we don't know. Today's briefing will examine the different immune responses the virus can produce, including those who develop long-haul symptoms. Your participation will inform Congress's work as we develop solutions to support COVID survivors, including long-haul research being pursued by researchers at TGen, the University of Arizona, Arizona State University, Northern Arizona University, and all across the country. Thank you for joining us for today's critical discussion.
Hi, I'm Congressman Eric Swalwell, and I want to thank you for joining today's Adaptive Congressional Briefing. I'm the co-chair of the Personalized Medicine Caucus, and I do that with co-chair Tom Emmers of Minnesota, Republican. The two of us understand the need to work together to better understand how personalized medicine can bring down the cost of medicine and expand the quality of care provided to every American. Enjoy today's congressional briefing. There's so much work to be done, particularly on COVID-19, to understand the long-term events and also make sure that we are better prepared for the next pandemic. Again, thank you so much for gathering and convening so many people who care about our health. And let's work together in this Congress to bring down the cost and expand quality access to healthcare.
Great. It was great to hear from Senator Sinema and Congressman Swalwell. At this point, I'd like to ask all the panelists to turn your cameras on while I quickly just put today's briefing into context. The Personalized Medicine Coalition actually organized a virtual caucus briefing on the personalized medicine community's response to COVID-19 just a few months into the pandemic. At that time, the emphasis had to be on the most immediate actions that were necessary to prevent the spread of the virus. We talked about the hurdles to ramping up testing capacity, emerging areas of therapy development, and efforts that were just getting underway to work on development for a vaccine. All we can offer at that time was hope that we were on the right track and that with mask wearing, staying home, and giving the scientific community time to get ahead of the virus, it would be enough to get us through the difficult experience we were all facing collectively. Even if you haven't had COVID-19 yourself, most people know someone who's tested positive for coronavirus or know someone who's become symptomatic to some degree. Many families have been impacted by the virus, my own among them. Each of our journeys has been different. The purpose of this briefing is to be sure you're all aware of the toll that the coronavirus has had in this country, and by the end, develop a better sense for the extreme suffering some individuals are going through. We also want to help you better understand the science behind what's known about the full adaptive immune response now, just a year after we held our first briefing, and why it's necessary to study immune response to answer questions we'll continue to face because of the coronavirus. And while we hope to never experience another pandemic, what we're learning about adaptive immune response may improve our ability to tackle any future pandemics. So we're going to start now with some prepared remarks for each of our expert speakers, and then we're going to follow it up with a moderated Q&A period. Our first speaker is Diana Behrendt, the founder of Survivor Corps. Diana is going to be telling us a little bit about herself, provide her perspective on what she and other COVID-19 survivors are facing, and her motivation for starting Survivor Corps. Diana, the next few minutes are all yours. Take it away.
Esteemed members, it is my honor to speak to you today. My name is Diana Behrendt, and I am the founder of Survivor Corps, the largest COVID movement in the world. Our mission is to connect patients and scientists and advocate for the needs of those who've survived COVID but are far from having recovered. I was one of the first Americans to be diagnosed with COVID, and I started Survivor Corps while I was still in isolation in my bedroom in March of 2020, long before we realized that there was a need for patient advocacy. At that time, you either lived or you died. But if you lived, you could become a citizen scientist, and you could lend your blood, your experiences to science and work in partnership to help to contribute to the body of knowledge that will help inform our medical future. While the count of the dead from COVID is staggering, I want to turn your collective attention to another number, the most conservative estimate of which is 33 million Americans who have been infected with COVID. The CDC almost a year ago estimated that 1 in 3 will suffer the long-term damage of COVID, otherwise known as long-term COVID. Recent estimates from Europe and Asia suggest a rate drastically higher. But even if we take the numbers at their most conservative estimate, we are talking about a population at a bare minimum above 10 million and probably substantially higher. We could be looking at the largest number of disabled young Americans in our nation's history, including wartime. That is sobering. I realize that there's been some confusion about what long-term COVID is. It goes by so many names: long hauler syndrome, long COVID, PASC, I could go on. But what we are talking about are the long tail symptom sequelae of COVID. When you hear me say that, you're probably thinking of a post-viral malaise or depression or anxiety. Let me be abundantly clear. We are talking about something much more severe, much more sinister. We have over 165,000 members at Survivor Corps. Here are a few examples from our membership. A 19-year-old college athlete who is now in a wheelchair. A young mother of 3 who is now reliant on a feeding tube and unable to take care of her own children. A 46-year-old professional who had to go out on uncertain disability plan because their ongoing symptoms impede them from making the critical choices they need to do to perform their job. How about the 11-year-old who's having seizures, or the 19-year-old who now has permanent lung damage? None of these people were ever hospitalized. You won't find their electronic health records under COVID, but that they are our shadow pandemic. They are the economic backbone of our country, and they are our children, our future. The baffling nature of long-term COVID is how differently it affects each person. One might walk away with permanent lung damage, another with neurological symptoms. It's not just debilitating fatigue, but also hair and tooth loss, serious organ damage, and impaired autonomic function. We started out thinking about COVID as a respiratory disease. We quickly understood that it was also a vascular and inflammatory disease, and I believe we will one day look back on it as largely a neurological disease. Its mechanism of destruction is still being understood, and the possibility that those with long-term COVID have yet to actually clear the virus is still a real possibility. Science will tell us in time. Personalized medicine, or precision medicine, whichever you favor, involves analyzing not just antibody responses, but T-cell signals, and also the multiple variables that come into play in every patient experience: their biology, their social context, their access to high quality care, and their economic experiences. When we took an initial poll at Survivor Corps in the summer of 2020, we found over 100 symptoms of long-term COVID. I'm sure that list would be twice that length today. The fact that this is such a heterogeneous group is obvious, as are their medical profiles, and so will need to be their medical care. Due to the tremendous differences in patient experiences, long-term COVID will need to be approached through precision medicine. These are not just patients. These are citizen scientists who are willing to engage in the scientific process because their lives depend on it. They are the resident experts on long-term COVID now because they are living it, despite having fallen through the cracks of our medical system that turned on a dime. Because during the pandemic, we eliminated the general practitioner and even the specialist from the medical landscape and instead used the emergency room as our first line of medical defense. And so most muddled through at home, like me. They are now begging for their granular medical information, and they are motivated to participate in the scientific process so long as their data is protected and the research is done on principles of equity, transparency, and collaboration, where citizens, as patients, are on an equal and respected footing with doctors and scientists. Survivor Corps members actually worked with Adaptive to bring its T-Detect test to fruition because Adaptive brought them along for the ride, bringing them up to speed every step of the way. And I'm telling you, you have never seen a group of people so eager to learn the differences between their T cells and their B cells and why it matters. To ignore the fact that personalized medicine is our destined future would be folly, but it won't come about on its own. We need investment and commitment to empower patients to be stewards of their own data so that we can make the proper decisions in a year from now along with our doctors. Every one of us has an individual immunological fingerprint. My entire family had COVID. My husband had an incredibly mild case, yet retained antibodies and a T-cell response for months longer than I did. One of my children has suffered vascular damage as a result of a mild case. The other one seems to be fine so far. How will we be able to make informed decisions in coordination with our doctors unless we can track our antibodies, our T-cell responses? And there's never been a more motivated cohort in history. If this is a conflagration point, I urge you to seize the moment to build back better. Offer a road to recovery for those suffering from long-term COVID and end this era with a system that is more equitable, more transparent, based on a collaborative vision of science and ultimately better prepared for COVID-29. Survivor Corps represents patients who are committed to being part of the solution to long-term COVID by collaborating on identifying needs, developing care, and pursuing answers through research. This caucus is committed to ensuring that the public and private sectors collaborate with patients in pursuit of prevention and treatment plans that are tailored more closely to patients' biological characteristics, circumstances, and values. We look forward and invite you to work with us towards these common goals. I thank you for your time.
Thank you so much, Diana, for that powerful statement. And our next speaker is Dr. Akiko Iwasaki, Professor of Immunobiology, Molecular and Cellular Development Biology, and Dermatology at the Yale School of Medicine. Dr. Iwasaki studies immune response to viruses. She's well situated to provide us with a big picture snapshot of why it's important to study immune response in the context of the coronavirus. Thank you so much, Dr. Iwasaki, and please take yourself off of mute.
Thank you so much for having me on this panel. My name is Akiko Iwasaki, and I'm an immunologist at the Yale University School of Medicine. I have been studying how viruses cause disease and how the immune system can either prevent or promote such diseases over the past 20 years. Infectious diseases is a combination of pathogen inflicting damage to the host and the host immune response causing damage to our own body. The study of the immune system is absolutely critical for us to understand COVID disease and to come up with an effective treatment. We have already learned over the past 15 months that COVID disease can be characterized as two separate stages. The initial stage is driven by the virus inflicting damage on the host cells. And the later stage is driven by the immune hyperstimulation that is harming the host. So depending on the stage of the disease, we must deploy different therapeutics. In addition to understanding COVID disease and treatment, without immunology, we would not have COVID diagnostics, such as antibody test or T-test that you will hear from Lance later. We would also not have monoclonal antibody cocktail to treat early phase disease. We would also not have a vaccine to bring the pandemic to end. So, but even after controlling this pandemic with the vaccine, we still need to use immunology to understand the disease pathogenesis of long COVID, as we've heard from Diane Behrendt. This is expected to be a very distinct phenotype from the acute COVID, and we are about to engage in studies where we can reveal the pathogenesis that underlie long COVID. Without such understanding, we will not be able to provide effective therapy to millions of people who are suffering from long-term consequences of COVID. The way we do science has dramatically evolved over the past 15 months. Just as an example, I am collaborating with Diane Behrendt, who represents the patients and citizen scientists, and Lance Baldo, who represents an innovative biotech company that came up with a critical way of analyzing immune response to SARS-CoV-2. We are collaborating together to find the science behind the long COVID. This is absolutely remarkable and is the way of the future. We hope to contribute to future understanding of long COVID and its therapy and cure. Thank you.
Thanks so much. Now we'll hear from Dr. Ned Sharpless, Director of the National Cancer Institute. The NCI is leading a number of COVID-19 activities. He will talk about some of those activities now and their connection to what we're learning about the adaptive immune response. So Dr. Sharpless, we will put your slide up and turn it over to you.
Great, thank you for having me. It's a real pleasure to speak to this group again on this topic. Maybe the first thing I want to address is why the National Cancer Institute. It's probably not obvious why the NCI would be working on COVID and the COVID immune response. A few reasons. First of all, coronavirus infection is tremendously important to cancer patients. We know that patients with impaired immunity, for example, have a worsened outcome with coronavirus infection. And so the impact of COVID infection on the patients with cancer is a very significant issue. Additionally, the fact of the pandemic has tremendously disrupted cancer care nationally. So I could talk at length about the 10 million missed screening events in 2020 related to mammography and cervical cancer, et cetera, because of the effects on the pandemic on the healthcare system. But lastly, perhaps less well known, is that the National Cancer Institute has a long and distinguished history in working in virology. So about 30% of cancers worldwide are attributable to viral infection. And so, the cancer researchers at the NCI have been working on virology really for decades, including, Bob Gallo, who invented the causative agent of AIDS, and Harold Varmus, who was an RA retrovirologist, and my colleagues Doug Lowy and John Schiller, who invented the human papillomavirus vaccine. And so there's a real expertise in the topics of vaccinology and immunology, and most importantly, serology, which is the measuring of antibodies in the blood to determine prior infection and to predict future infection. So because of that expertise and an existing lab at Frederick National Lab, which was already working on serology for other viruses, it was relatively straightforward for the NCI to pivot and take on coronavirus research. One of the first things we did was a collaboration with the FDA to try and understand how these devices work. So the FDA was being inundated with antibody detecting devices of various quality, and they asked the National Cancer Institute to do some proficiency testing at Frederick National Lab, which we have done and now validated in more than 100 different kits for the FDA, and those are now commercially available products in some cases. We also were funded by Congress eventually. So Congress, in the fourth supplement last April, provided $306 million to the National Cancer Institute for COVID activities. And that's what the slide shows. And this is the sort of things we have done related to coronavirus research with support from Congress. And the language from Congress asked us to work on serology and related technologies. And the reason that's an important question is serology and related technologies get at two essential questions related to a pandemic. One is, it's a way of estimating who's already had the infection, which is important for a number of public health matters, including predicting the risk of a population for a future outbreak. And the second important question related to serology is some ability to predict who's likely to have a future infection, who's at greatest risk for additional infection. And so, really developing that technology and learning the clinical features of antibody detection and their use in coronavirus patients was, really job one of the NCI starting, last spring. And these are the sorts of things we've done. We've funded clinical trials, we've funded seroprevalence surveys and seroprotection surveys. We've created a big database of seroprevalence with the help of the CDC called SeroHub. We've done the FDA testing. We've sponsored certain therapeutic trials. We've created digital tools for coronavirus research. We have a large over 1,000 patient accrual trial to study the effects of coronavirus in patients with cancer and their long-term outcomes. That includes longitudinal sample collection. And I think that will be a key resource for really investigating this question of the long COVID syndrome and the post-acute sequelae of COVID infection. And lastly, we created this network called SeroNet of, these are grants and contracts to 25 academic institutions that really have some of this sort of cutting edge foundational science to study coronavirus, the immune response to coronavirus. And that group is doing both basic immunologic investigation and virology research, as well as clinical research to understand the impact of coronavirus infection on antibody production and other markers of immunity, as well as future risk. One thing we did through this study, for example, was an early report using a real-world evidence approach to show that individuals who were antibody positive, i.e. likely had prior coronavirus infection, were therefore less likely to be reinfected in the future. And that was an important piece of knowledge that I think we all know now, but was news when we published it a few months ago. One of the things that's come to light through these investigations is that antibodies are not enough. So this related technologies business becomes very important. And one of the things that we believe the NCI is very critical for addressing both of those questions, both prior infection and risk of future infection, is an understanding of cellular immunity. And so that's the T cell response that others have mentioned already. And so we are trying to use various assays, including the adaptive assay, in these various cohorts within SeroNet to study the interaction between humoral, antibody immunity and cellular immunity, and other questions such as prior infection and risk of future infection. And I will stop there and just say I really thank you for the interest and the opportunity to speak today, and would be happy to answer any questions about the NCI's efforts in this area.
Thank you, Dr. Sharpless. I know we did a great disservice to you at NCI, giving you less than 10 minutes to talk about all the amazing work you're doing, but you did a terrific job, and especially tying it to what we're talking to everyone about today. So thank you again. Our next speaker is Dr. Lance Baldo, the Adaptive Biotechnologies Chief Medical Officer. Dr. Baldo is going to cover T cell response and specifically why we look at it and what it tells us. So Dr. Baldo, please take it away.
Thanks, Cynthia, and thanks to the Personalized Medicine Coalition, especially to the caucus, for taking up what's such an important topic. And as humans, as biologic systems, we're pretty fortunate that we have a lot of built-in redundancy to protect us in most cases from infection, or at least if we get infected, to help us to clear that infection and maybe even protect us in the future. And we have a number of different ways to do this. And you've already heard about some of them mentioned by the other panelists. The most obvious when we look at ourselves is our innate immune system. Our skin is perhaps the best or the most obvious manifestation of that. And it protects us from infection without even knowing it. In fact, that's why hand washing can be so effective. And then there's adaptive immunity, and Dr. Sharpless addressed this quite well. Humoral or B cell immunity, and then cellular or T cell immunity. And all these different parts of our immune system work together really like a symphony to try to keep us protected and really keep us alive. Those antibodies that are tested by serology, they'll stick to the pathogens and they'll stop them from spreading into cells. T cells, they surveil our body and they often respond early and they help those B cells make antibodies. They also look for the cells in our body that have been infected. Cells in our body that get infected kind of throw up their hands and say, hey, something's not right. And then T cells will come along and basically eradicate those cells or help to eradicate those cells. And then finally and importantly, your T cells will stick around for a very long time. Often in the case of some of the prior coronavirus infections, they'll stick around for a number of years. And they kind of stick around to jump into action should you ever get infected again. And over decades, and it's a lot of the technology that was implied in SeroNet by the NCI, we've developed a really deep understanding of antibodies and lots of great ways to assess them. But a lot less has been known about T cells. And some of that's due to their diversity and complexity. And having been in this industry now for a number of years, the tools that we've had until recently were pretty cumbersome and really hard to use at scale, particularly in the setting of a worldwide pandemic. But luckily, advances in sequencing and machine learning have now made it possible to study, read, and translate the genetics of the immune system of those T cells and of those B cells. And a key factor in this has been the convergence of tech and biotech, making what's possible today was not possible 5 or especially 10 years ago. And at the beginning of the pandemic, Adaptive was already working with Microsoft. And we saw that the technology that we were developing for other applications had application in this public health crisis and more insights were needed. So we took this platform to try to see what we could learn that would be complementary to the clinical data that was being developed and the serology data that was being developed and continues to be developed by initiatives such as SERANET. So really trying to fill in the gaps and really complement some of the antibody work and the serology work. So we've identified literally thousands of samples from patients with COVID around the world. A lot of them were with the help of Survivor Court and Diana Behrendt, these citizen scientists, to really try to rapidly learn as much as we can about T cells. And this work led to three really important things. One is a public database called Immune Code, where all of this T cell information and how those T cells map to the actual parts of the virus is made available publicly and free to researchers all around the world. Next was a T cell test called T-Detect COVID, which we worked with the FDA to get and garner emergency use authorization. And this is a test that picks up people and establishes a past history, a medical history of having had COVID. Antibodies, for all of their great features, they tend to wane over time in the setting of really any infection. And T cells tend to stay around a little bit longer. And so there's applications of T cells to be able to pick up this past infection. And then finally, we created a tool to be able to map T cells to the parts of the virus. And this is important in the setting of vaccine development and manufacturing to see what types of T cell responses are elicited by vaccines. So in summary, applications of T cells have a lot of import within the setting of COVID to be able to, number one, detect disease. Number two, in the setting of vaccination, to try to understand who might be protected, and really importantly now, for how long. And also, and this is really near and dear to Dr. Sharpless, really vulnerable populations such as immunocompromised patients who just may not be developing a robust B cell or antibody response. And could the T cells be protecting some of these patients, some of these people? And then finally, and importantly, as Diana referred to, long COVID, while many of the acute symptoms may dissipate, some chronic symptoms are often taking their place. And how could we look at both antibodies, T cells, and other parts of the immune system to see just what the heck is going on? And so I just would encourage that when you think about your policies, your priorities, really about your constituents, just remember that we need to focus on every tool at our disposal to keep this pandemic under control and really make sure that we're able to manage those long-term consequences of COVID. I thank you for your time. Back to you.
Wonderful. Thanks so much, Lance. Last but not least is Dr. James Kublin. Dr. Kublin is the principal staff scientist in the Vaccine and Infectious Disease Division at the Fred Hutchinson Cancer Research Center. Dr. Kublin's part of the COVID Prevention Network, and he'll share some thoughts on how we're doing on COVID vaccination. Specifically, he'll talk about some of the outstanding questions related to the COVID-19 vaccines and what's being done to answer them. So Dr. Kublin, please take yourself off mute.
Thank you, Cynthia, and certainly thank you to the caucus for convening this panel and the invitation to join you. I'm a physician scientist. I've spent most of my career focused on HIV, TB, and malaria, very different pathogens, a virus, a bacteria, and a parasite. And in early 2020, I was also functioning as the executive director of the HIV Vaccine Trials Network. We had over 100 clinical sites around the world conducting HIV vaccine and passive immunoprophylaxis studies. And of course, just over a year ago, we pivoted to the COVID-19 Prevention Network activities. And by last summer, had over 200 sites around the world where we were conducting COVID-19 vaccine clinical trials. And this includes these large phase 3 efficacy trials that have been conducted over the past 9 months here in the United States, as well as globally. So I have the great honor of working with these hundreds of sites around the world, thousands of frontline workers who have been contributing to investigating, discovering, finding these fantastic COVID-19 vaccines that we now have at our disposal. And that includes, we've contributed to the initial design of these studies, how many people are critical to be included in the studies, what sort of time point and regimen we'll be investigating, how to measure the immune response, and at what time points, what assays may be critical to conduct those measurements. We've also been, of course, very involved in the community engagement that is so critical in the course of conducting these vaccines and reaching critical populations that are a priority for us as we've seen health disparities impacted not only the outcome of COVID itself, but also the critical contribution they've made to these phase 3 clinical trials. One of the things that we're very focused on intensively right now is looking for these immune responses that are elicited by the vaccines that correlate with protection, what we call the correlates of protection. And there are very intensive analyses underway right now on some of the early vaccine studies that were launched last summer, such as the Moderna vaccine that was followed by as well Pfizer and AstraZeneca and Janssen and the Novavax vaccines. All of these clinical trials have collected samples from which we can measure these immune responses that then correlate with protection. And when we've identified these biomarkers, essentially, of how well the vaccines work, we're much more able to pivot frequently to keep up or potentially stay ahead with the variants of concern so that we maintain high levels of vaccine efficacy throughout the pandemic and perhaps indeed in anticipation of future pandemics. A recent publication just this week from colleagues at Duke, Dr. Haynes, has demonstrated that there are potential immune responses that would protect us not only from the existing SARS-CoV-2 variants, but beta coronaviruses that may emerge due to these trans-species transmission events that really are the precipitating event that causes these global pandemics. We've witnessed the tremendous progress we've been able to accomplish in the past year, and I'm very excited and energized by what we've learned about this virus, and also then how to apply that to some of the existing pandemics that we've been wrestling with now for decades, if not millennia, such as HIV and TB, respectively. So with that, I'm looking forward to the Q&A session, and thank you for your time.
Great. Thanks so much, Dr. Kublin. So now I'm going to ask all the speakers to come off of mute for our question and answer period. We just like to delve a little deeper into some of the topics that we touched on in each of your opening remarks. First, I'd like to ask Dr. Iwasaki a question. What strikes me from Diana's overview and also some of your opening remarks is just the variability of responses we're seeing from COVID infection. There's everything from asymptomatic to a wide range of symptoms, very sick and people who are dying. What are we really learning about this variability? And is it specific to coronavirus? Is it related to our individual immune response? And you mentioned that this is a way that we can look at targeting interventions, prevention. So we'd be really interested to hear more from you on that.
Right. So what we're learning about, as you say, is that COVID-19 disease outcome is quite variable and heterogeneous. Even amongst the similar age group, we're seeing very different responses depending on the person that's being infected. So research has now shown that the symptoms and outcome of COVID is closely related to the immune responses that are generated. So in general, early innate immune responses that can control the virus before it spreads from the nose to the lung to the rest of the body is able to clear the virus and help somebody recover with a milder disease. And we know now that patients who have deficit in these types of innate immune responses develop life-threatening diseases. So we can help these patients recover during the early phase by giving monoclonal antibody cocktails. On the other hand, later stage of COVID is driven by the overdrive of the immune response. For example, we showed that even the neutralizing antibodies that develop too late in some people are not helpful at all, and it's associated with mortality. So by that stage, COVID appears to be driven by the immune reaction, including autoimmune activation and potentially antibody-dependent pathologies. So that is why anti-inflammatory drugs like dexamethasone and tocilizumab, which is an antibody that blocks the cytokine signaling pathway, can save lives of these people on oxygen support or ventilators. So we have to really treat COVID as two separate diseases depending on its stage. And we're not even learning enough yet about the long COVID to really understand what is driving the long COVID versus the acute COVID. And that's something that the scientific community is currently starting to engage in.
Thanks so much. Does anyone else on the panel want to share their thoughts on that question?
I guess the only thing I'd add is the tremendous amount of heterogeneity that we're seeing in the patient responses. And as Dr. Iwasaki points out, some of that's probably, if not certainly, due to differences in innate immunity, but then also differences in terms of how people are responding over the long run and that interplay between the host and between the pathogen. And I really, looking forward to some of the future collaborations and really trying to tease all this out in the setting of long COVID, particularly in the setting of some of the long COVID centers that are cropping up now, where we hope that we can generate more information to inform for today, but also inform for the future.
Great. Thank you.
I will obviously, of course, always second the need for more long COVID care centers. And I've been working closely with the Mayo Center, which I know is of interest to those here representing Minnesota, Arizona, and other states, but really creating what could be the template for a tiered system of long-term COVID centers. And because Mayo is affiliated with, has a rural network of hospitals, it is so important that we consider that every community is serviced, because there's not a community in America that has been spared by COVID. And, you know, it doesn't take much math to figure out that there's been no community spared by long-term COVID. Absolutely.
So we're going to move on to a question that's been top of mind to a lot of folks who registered and submitted questions in advance. We now have over a third of Americans who are fully vaccinated, and many more who are on their way. There's been the very recent authorization for vaccination of younger teens. We know that these vaccines are extremely effective, but there's so many questions that are still out there. Some of what we've heard is, how long will the protection last? How are we defining immunity? How will we know when it's time for a booster? Can an individual person check if they have immunity? And what if you've had COVID already? Are you actually protected? We also had a question that was submitted this morning from a congressional office that asked us, what's the probability of someone actually being harmed by a vaccine? I just had my second dose administered last day, so selfishly, I'm very curious to hear your thoughts on a number of these questions. So we'll start with Dr. Sharpless and then move on to Dr. Kublin.
Sure. I will say off the top that a lot of the answers that are just not known yet. I mean, this is still early days, and this is an active area of clinical research. And these are exactly the kinds of questions that something like SeroNet and efforts by NIAID, the National Institute of Allergy and Infectious Disease, are really set up to try and address. Is the duration of vaccine efficacy, the various outcomes of patients who are vaccinated in terms of the signatures of immune response, et cetera. So I think that what we know today is the vaccines appear to be highly effective. They appear to be highly safe. I had a stint at the FDA where we regulated several vaccines, including the dengue vaccine and the Ebola vaccine. And, often vaccine development is very complicated. And I think, the progress made against coronavirus in such a short time is unbelievably remarkable. It's really without precedent in vaccine development. And I think none of us envisioned that it would be so successful in terms of both efficacy and safety this quickly. But having said that, there's still a significant additional clinical research to be done related to the effects of vaccination. And so I think what we can say today is, basically the advice the CDC has been giving the public that, these groups of patients should be vaccinated. And but we continue to learn every day new things that will address the questions raised.
Great, thanks so much. And Dr. Sharpless, we know you need to leave us a bit early, so thanks so much for your time on the panel and your presentation and everything you're doing. Take care. Dr. Kublin, your thoughts?
Yes, I'd add to that, the question around durability, as Dr. Sharpless alluded to, is a critical one. and that we're really just beginning to answer now. We've had preliminary reports from the early mRNA studies that the durability is quite sound, at least 6 months, and it could be easily 12 months. And that durability may be better post-vaccination than post-infection, in the rare circumstance in which vaccination provides even better immunity than the natural immunity acquired from infection. So we're certainly encouraging people who have previously been infected to seek vaccination. And that is, of course, a major interest, of course, in preventing the emergence of new variants. The more people who are vaccinated, the more successful we will be in controlling the pandemic. And that does include the emergence of these variants. So when it's time to get a booster and these other questions about checking the immunity, the durability of this immunity, as I mentioned earlier, these correlates of protection analyses that are ongoing this month, we're hoping to have preliminary data by the end of the month, will be critical to inform the answers to these questions. And so I'm very excited about the coming months. We'll have some very concrete answers that I know many of us have these very specific questions. And you know, the tremendous and really remarkable success of high levels of efficacy against SARS-CoV-2 really is a testament to decades of investment in science, in basic research that then can be applied and translated to the clinic, and just making that pitch to those of us who continue to advocate for critical science funding through the spectrum of basic research all the way through into the clinic.
Thanks so much for that, Dr. Kublin. And the Personalized Medicine Coalition is a major advocate for annual appropriations for the National Institutes of Health. So we would second the need for continuing to support that type of research as well. So you did actually segue very nicely into the next question about variants. Does anyone else have any thoughts that they'd like to share about the emergence of variants and what we're doing in the current state of where we're at with understanding vaccines and how it can lend to potential resistance to some of the emerging COVID variants?
I can add another plea for everybody to get vaccinated, whether or not you've had a natural infection. At Survivor Corps, this is anecdotal data, but of our 166,000 plus members, we're seeing a reinfection rate of over 10%, 10 to 15%, half of whom are the second case is not as bad. The other half, it's much worse. There's no clear pathway on that. And from my own personal experience, I actually received the first antibody test in America on March 28th of 2020 and tracked my antibodies all the way through. I donated plasma 8 times. I knew that I had a high titer level. I was out of antibodies by October, November. And so that's just a sign that, they don't, my kids still have them, my husband has them, but each person really reacts differently. And I just made appointments for my 12-year-old and my 14-year-old to go get vaccinated tomorrow, even though they both had COVID already, because the best way to avoid long-term COVID is to avoid COVID.
Yep. We'd all agree with that. So now I'd actually like to switch gears to a topic that we heard about quite a bit in the beginning of the program, long COVID. We know that there's been a lot of congressional interest in this topic from last week's hearing. Unfortunately, we only have 60 minutes. We don't have 6 hours to discuss the topic, but we just wanted to touch on a few key points as it relates to immune response. Diana, we understand that you've been hearing a lot about COVID and long COVID from your community. Can you tell us when you first started hearing about the long-term impacts of COVID-19 and those who have recovered from that state of the disease? And when did it be clear that it was something that was really a large-scale problem?
I started Survivor Corps on March 24th of 2020, realizing that if I was going to be one of the first survivors, I could mobilize an army of survivors to donate their plasma and to connect with science. I'd say it was by mid-April that we started to hear from many members of our Facebook group, which was already at 30,000 at that point, that they were not recovering. And it was one of those things that we had enough people to see trends. And that's been one of our great uses, is that we are seeing trends on the ground, and we can take that information and bring it to people like Dr. Baldo and Dr. Iwasaki to, see what is actually going on. We can give them anecdotal reports, and they can do the science to figure out what is actually happening. And so that's what we started to do in April. We got our first primetime news piece on long-term COVID on May 17th, I believe, last year. So we have been screaming from the rooftops about this for months and months. I interviewed Dr. Fauci on the topic in October. But as the numbers have just increased of how many people who have been infected in the country, the percentage of people, everybody knows somebody who is suffering from long-term COVID, and a lot of them are children. And that is, to me, very, very frightening. And I'll give you one other personal story. My son had a very average case of COVID. He was 11. Actually, before I did. We later confirmed it by antibodies. And, I never would have called him a long haul kid at all. And then 9 months later, one of his front adult teeth fell out spontaneously with no blood loss from vascular damage from COVID. And we found that 28% of our membership was experiencing new and unusual dental issues, 14% reporting teeth cracking, crumbling, and falling out. That is every American's economic worst nightmare. Not only is it the sort of Freudian nightmare, it is also a financial nightmare. And so we need to think about all of the many elements of long-term COVID and what how people are insured differently for different organs, and how we are going to address this holistically.
Thank you, Diana. Akiko, do you have any additional thoughts that you'd like to share on the biology and potentially what's happening in long COVID?
Yeah, so I started hearing about long COVID around the time that Diane had reported on it. And around June of last year, I came up with a couple of different theories that could explain long COVID. One theory is that there is a persistent virus infection that is not detectable by the nasopharyngeal swab, but it's somewhere deeper that's chronically stimulating the immune system of the person and having these long-term consequences. The other possibility is autoimmune syndrome, that that our own immune system is starting to attack our own cells, and that could also have long-term consequences. And as Diana mentioned, there are over 100 different symptoms that are reported for long COVID. And depending on the specificity of the antibody, we could explain some of these diverse symptoms based on that. So, and we already know that diverse autoantibodies develop during acute COVID. And it's, it's unclear right now whether that's really contributing to the long-term symptoms. But those are the two hypotheses that we're testing right now.
Great. Lance or Jim, do you have anything you want to share on that?
I'd only add that, to Akiko's point, what we can do about it and how to intervene, I know is one of Diana's priorities as well. There's anecdotal evidence of people with having received the vaccine with some improvement of symptoms, albeit perhaps transiently. So I think there's a tremendous amount to do in considering therapeutic vaccinations for these individuals and different immunotherapy approaches that I think deserves a lot of attention and is quite an exciting field.
I just to add to that, there's really three parts to this I see. One is kind of trying to establish that medical history of COVID, whether that's through antibodies or T cells, to try to figure out who in fact has had infection in the past. The second is trying to figure out what's going on. And that's where there's so much research right now to figure out, is this reservoir, is this our immune system attacking ourselves? I have a feeling it's probably some combination of both. And the third, as Dr. Kublin points out, is what are we going to do about it? And so I think we're going to have to handle all three parts of this really difficult problem together at the same time.
I would add that there's also an element of organ damage that's going on through damage to the endothelial lining of the vasculature. You can end up with micro blood clots in just about any organ. So we're seeing a sharp increase in diabetes. We are seeing verifiable brain damage. We are seeing actual destruction of lung tissue and heart muscle fibers from really, really mild cases of COVID. And so for all of this research, we also need to keep in mind that it's not going to be a panacea for everybody who is suffering the long-term effects of COVID. And we need to figure out a pathway to recovery for everybody. So this is one route, but we need to consider every person's experience, and many are going to be a combination of all of these.
I think we have time for one more question. And there was a question that came in from a congressional office, and given that they were the primary audience for this educational briefing, I'd like to tee it up. And Diana has alluded to this a couple of times. Some clinicians have characterized COVID-19 as a vascular disease. Can you please comment on why they believe that this virus should be characterized this way?
I'm happy to take that unless an actual doctor wants to.
Why don't you start, Diana, and then we'll
So my understanding of it is this, and maybe perhaps my layman's or laywoman's interpretation will be the easiest to understand. So the vasculature is the endothelial lining is like the paint at the inside of your house that keeps everything smooth and running clearly. And so you want that to be smooth like an ice skating rink. You want it to be like the Zamboni just went over it and everything can go smoothly. Well, what COVID does is that it's more like right at the end of open skate time on your endothelial lining. And so it's creating all this disruption, and you end up with these tiny little clots that can end up in any organ of the body that relies on blood supply, which is, by the way, all of them. So that's why we're seeing everything from, I was diagnosed with COVID onset glaucoma. They found fraying of the microvasculature in my eyes. We are seeing a lot of reports of erectile dysfunction because remember, every organ relies on blood flow. We are seeing ocular issues. We are seeing tinnitus. We are seeing hearing loss. We are seeing damage to nerves, to, my son's tooth loss. That's from a blood clot and we are still trying to figure out, was it in the jaw, was it in the tooth, was it in the gum? Those are very vascular areas. So this is going to be hard to unwind, but I hope that was I now feel free to be corrected by the actual doctors in the group.
I love the Zamboni reference. It seems very, very apt, and I'm going to use it. Because it's a very clear description, I think, of the hypothesis behind why this is a vascular illness. And as Dr. Iwasaki also highlighted, there are these multiple phases. The virus itself in its replication results in immediate local damage, but there's also the immune response, and that immune response secondary to infection can also disrupt that smooth surface.
Well, there were no additional questions that came in. So I think we'll just take this opportunity on behalf of the briefing organizers to thank you all for joining us, and also thank all of our speakers for their insights today. We appreciate all of you as experts, particularly experts as patients who have been through this condition. We now have a better understanding of a lot of the tremendous work you're already doing to help us move into the future with a more targeted response to the virus and others that we may face. But we still have a long way to go. So we need to keep our eye on the ball and make sure that we're providing support where it's necessary. It's a response that we believe is truly focused on the individual patient needs. And I can say that the Personalized Medicine Coalition, that's the approach that we're all about. I will thank Adaptive for asking us to be a part of the program and also to lead the discussion. I would also like to give a thanks to the staff of the Congressional Personalized Medicine Caucus, Connor Sheehy from Senator Tim Scott's office, Ryan Altman from Representative Emmer's office, Sylvia Lee from Senator Sinema's office, and also a new staffer named Sarah Shapiro in Congressman Swalwell's office for all that they do to make sure that briefings like this are possible, but also their continued work in advancing personalized medicine. It's incredibly important. There have been some questions about whether or not this briefing will be available. I believe it is being recorded, so we will do our best. And there have been some very specific questions that have come in, some that have been related to the program and some that have been more related to other issues. We'll do our best to triage those questions and see if we can get you some responses offline because we have your contact information. That this has been informative and it's not the last time that you engage with us. And I hope you all have a wonderful day. Take care. Thank you.